All right. Well, it's 6:32 and it looks like we're starting to get a critical mass. So I'll go ahead and get it kicked off here. So welcome everybody to this iteration of the West Coast Fellows Conference. Great to have everyone here, and would very much like to thank Venkat Ganapathy for leading this session today. He's going to speak about ankylosing spondylitis, which is, I think anyone who's dealt with it knows, a very challenging pathology. So it'll be great to hear the lessons that you've learned. Venkat, professor at the University of Arizona, does a lot of the complex deformity there, associate editor of JBJS, and somebody that our fellows, I think, will be able to learn a lot from. So without further delay, I'll turn it over to you, and thanks again, Venkat.
Thanks, Honey, for those kind words. Got the screen sharing go. It's my so I shared my screen. So there it is. Okay,
perfect. You're good. You're good.
Great. Okay, so I thought I'd talk about the overview and principles of ankylosing spondylitis. As Dr. Malone was mentioning, this is not an uncommon situation to see in practice, and can be daunting both in terms of how it presents and the risks associated with this and the stakes. So our objectives today are basic understanding of ankylosing spondylitis and emergency management principles. I thought we'd just focus on thoracolumbar fractures because there's a whole paradigm of ankylosing spondylitis, and we could take this in different directions: cervical, thoracic, deformity, etc., acute versus chronic management. But I just wanted to spend time discussing the emergency management principles and the treatment options for thoracolumbar fractures. And we'll try to make this evidence-based because there's a lot of questions that come to people's mind. So what we're not covering is, we just talked about that, is deformity and cervical. I don't have any disclosures. So I just thought we'd start at the case. So this is a case that I actually had when I was in residency. So this is a gentleman who was seen in the peripheral hospital in his 70s, I believe mid-70s, came to the hospital with some back pain, and they thought it was a compression fracture, was discharged home to rehab. 4 weeks, continued to have severe pain, and presented to the ER because now he's having really difficult time walking. These were his presenting x-rays at the initial visit, and then this was the subsequent x-rays in the hospital 4 weeks after. And of course, on the lateral, something doesn't quite make sense depending on how you see it. But the show and tell x-ray here is ankylosing spondylitis, and how you can pick that up versus dish is there's involvement of the disc space. And if one of the exam questions that comes up is, if there's one x-ray you can take to diagnose this, would be the SI joint. And as you see on the AP x-ray on the left, patient has completely fused SI joints there. So this is not dish, this is ankylosing spondylitis. And so the presentation, as you see there, there's something different about the end plate of 3, and the L2 on L3 is translated, as you can see, as you can appreciate. So the initial sagittal CT, I'll try to see if I can run through this. So you're seeing end plate changes, translation, as well as a 3-column injury on this CT. And MRI was done, obviously, for completion of workup. Patient had difficult time walking, mainly because of pain. And as you can see here on the sagittal T2, there's no significant canal compromise. But, I'm sure everybody here knows that the reason likely he's not able to get up and walk around very much is because of the severe pain that he's got. Before the advent of CT and MRI, this was called an infection, which is why people started using the word spondylodiscitis, because they thought it was an infection, came from the disc space itself. But with the advent of CT, it was understood that it was more of a non-union as opposed to a true infection. Okay, I'll skip the, so management of choice in this patient, we decided to go percutaneously, and at the time we didn't have any navigation, so we went through a percutaneous technique with x-ray guidance. The indications were instability and severe back pain, and we decided to do 12-5 with percutaneous fixation, minimal blood loss, and as most people would expect, no complications in this patient, but there's a whole list that that can occur, and we'll talk about that. Positioning, the key thing here is everybody knows this is a Jackson 4-post, but the key thing here is that the chest, you have to build it up to keep the patient in situ. And there, there's techniques where you can use serendipitous reduction and use that extension to your advantage to give patients or get them out of a chin or chest deformity. Although, there's only so much power you can get with this. I don't want to belabor this, but everybody knows here how to put a pedicle screw in. So you can use X-ray or as noted there, and then you can use navigation. So I use navigation now for 90+% of the cases, except decompressions or ACDFs, etc. But this is how we drape our patient, and of course, guide wire insertion, and then you have your sequential dilatation. And then you tap it, and then you basically put your screws in with the extenders, and then you run your rod through the towers, and then you confirm it and finally lock it. And this is how the skin closure appears after that particular surgery for this patient. So this is what we had done in residency. So we went 3 above and 3 below in order to stabilize it. And we'll talk about some of the evidence behind this. And this is our patient who was able to leave rehab after 3 or 4 days, as he didn't have thankfully, any complications. So a case 2 here. This is one of our recent cases here at U of A. This is a patient who presented with, again, a 3-column injury, as one can see. But this patient came in with paraparesis, and as you can see on the far right, sagittal T2. There are some already cord signal changes that one can appreciate. That this is a very unstable injury. This is what we had done, but what I'd like people to pay attention to is look how we were with our instrumentation in situ, and then post-operatively, see how he settled quite nicely, and then the kyphosis that one can get. Obviously, the left picture is a CT scan, which is a supine image, but the patients do settle. In terms of, because the body is a lot stronger than a cobalt chrome. And I hope this video works. So this patient who has paraparesis was able to, thankfully, have a pretty good clinical outcome because of the timing of the surgery. So what is ankylosing spondylitis? It's also called, I'm going to mispronounce this name, is Beck-True disease. And there's many different names associated with ankylosing spondylitis, partly because we didn't understand what this actually meant. It's an inflammatory spondyloarthropathy. It affects essentially every aspect of the joint, mostly the spine, SI. You get enthesis, which basically is where you get insertion of the tendon into bone. A classic location would be the insertion of the Achilles on the calcaneus. The key thing in the second point is that if patients present with severe eye pain, that's a medical emergency. Otherwise, people can lose their vision. Uveitis is a big problem. There is an association of HLA-B27 with this, but we used to do, when I was a medical student or a resident, we used to be doing HLA-B27s as a way of diagnosis, but it's not sensitive or specific, but there's a high association with this. The reason why you get the other associated inflammatory process is molecular mimicry, and they've proposed it between Klebsiella pneumoniae and HLA-B27 as a way to initiate the process. Imaging manifestations of spinal fractures. So, a summary of this basically is that X-rays are not adequate. You can easily miss it. CT is better than X-rays, but depending on your slices, if you get anything more than anything like a 2 millimeter slice or more, you can miss it. So a patient who presents in the emergency room with a fracture, with a fall or a trivial injury and has severe back pain with the underlying radiological or clinical manifestation of ankylosing spondylitis, always have a low threshold for MRI. Very similar to the ortho residents or fellows here is, if you had a fractured hip, or at least a suspicion of it, and you can't demonstrate it on an X-ray or a CT, you go for an MRI. Very similar principle. The imaging issues, I think we just talked about this, so I'm just going to skip it. get to more relevant. So in essence, all these papers talk about the fact that MRI is more sensitive and therefore is recommended as an adjuvant. In our hands here, we typically use an MRI if patients have, the reasons to get an MRI to justify is epidural hematoma, which is high on these patients. And as part of your preoperative assessment and understanding to see if you need to do an additional decompression, then an MRI could be warranted. Not everybody needs a decompression, but this will give you the information to proceed. So the question was, is routine MRI necessary in patients and is CT sufficient? The routine use of MRI, based on this retrospective review, they said was can be limited to non-ankylosing level, but as we just talked about it, it's not the first line, but you should use it if there's any missed injuries or any clinical suspicion. So management challenges. So emergency room management is key as a patient comes in, heightened suspicion for an occult fracture, as we just discussed, based on, you don't even necessarily have to have an X-ray or a CT to have a clinical suspicion. Patients who have a chin on chest type of a deformity, or they're not able to lay their head down and essentially have a difficult time maintaining their posture on the bed, you have to have a clinical suspicion. One of the common things that paramedics do is basically extend people down, pin them down, or get them on a backboard, get them to lay flat with the C-collar. You have to be really careful about this. And part of this is education to your emergency room, the paramedics associated, to make sure that we don't miss such a thing. And I'll show you some pictures. It also poses diagnostic challenges because of bony sclerosis and syndesmophytes. And we talked about the usefulness of imaging. You have to be highly suspicious of non-contiguous injuries. One study looked at 6 to 8% of the where you can have missed injuries, but other studies showed 13 to 15% associated non-contiguous. So you do have to image the whole spine, even if one is obvious in terms of a fracture. Be aware of atlantoaxial subluxation. There are certain conditions that come to mind that you have to be awfully suspicious about. Ankylosing spondylitis is one of them. Pseudo achondroplasia. Patients obviously with trisomy 21. So this is one of those. Keep this in your mind as part of your preoperative evaluation assessment. The techniques are different, and I have a picture to show that, but always be careful, suspicious, and have your patient admitted in a place where they can have close follow-up in the hospital before treatment, definitive treatment, either non-op or op, mostly op, and then for epidural hematoma or progressive neurological deficit. These patients are high risk for airway issues and spontaneous pneumothoraces, so you've got to be careful. So pulmonary toilet is key. These patients inherently have a reduced total lung capacity, vital capacity. They have low forced vital capacity and low forced expiratory flow in the first second. So this all can pose challenges intraoperatively as well as postoperatively. Patients who come in to the hospital like this, having trouble, please do not extend them. Try to put them where you want them to go. Always build up with pillows to try to get to that position. And the same thing with if you were trying to treat something non-operatively for whatever reason, keep them in their natural state. There is a role for extension, but that's beyond the scope of this talk today. So the operative challenges, I just want to have a summary of a slide. So preoperative, we talked about the airway, the positioning, and then the diagnostic differential, anesthesia, airway. In our center, we typically try to get anesthesia to have a look at them just before the case to ensure that there's no challenges or surprises. Always be suspicious for an atlantoaxial instability. I'm not saying you should spend time trying to rule that out, but keep that position, keep that in mind as you're evaluating your imaging. Intraoperative, we talked about the positioning challenges. Build the chest pad to be able to accommodate their natural state, so that the patient's head doesn't go too low, or you extend them inadvertently. Bleeding is a significant issue. I don't know how many people remember this from medical school, that ankylosing spondylitis is a hyperdynamic circulation situation. So that's why you get epidural hematoma and there's a high risk of bleeding. also because patients have osteoporosis and they bleed through their trabecular bone a lot. They can get iatrogenic fractures, which is very, very important. So be careful and double check and triple check how your positioning is with X-rays before you even start the case. We talked about the postoperative issues to keep an eye for the epidural hematoma. Typically, postoperatively, our protocols to keep them Q1 neurochecks at least until 24 hours until we go back to regular Q4 neurochecks after. And then also in the rehab and mobilization, educate your rehab physicians and make sure there's documentation as to how you want them positioned, you want to brace or not in addition. Intraoperatively, the issues are if you don't adequately position them prone, you can increase your intra-abdominal pressure, which reduces the IVC flow, and that causes increased pressure in your azygous venous system, causing increased blood loss, which can also cause injury. Because of the chronic inflammatory state, and because of neovascularization, another reason for increased blood loss. And as we discussed it, if the chest pressures are high and you have increased ventilation pressures, that's going to affect your chest, your ventilation, and your VQ. We've had several cases in our center where patients with a similar ankylosing condition could not tolerate prone position. Although if you talk to anesthesia staff in ICU, prone position is better tolerated for ventilation because your VQ ratio improves in prone position. And I'm sure people here have seen how prone position can help with pulmonary toilet. There are certain beds associated with so, but it is helpful. But be careful because already they have low compliance, and if you have high ventilating pressures, it makes it for a difficult case. Differential diagnosis, I won't belabor this point. The natural history, typically it's in the 20 to 30s. Early symptoms are low back pain, stiffness. It's a balance of when back pain resolves, usually they get really stiff. The etiology of ankylosis is not well defined. The post-fracture challenges, as you all know, because of the high lever arm, and I'll have a picture to show that, it's a inherently unstable fractures. It behaves like a long bone and has a high propensity for 3-column injury. Additional osteoporosis makes 360 degrees at least as consideration, although we'll look at some of the evidence. 360 has a higher incidence of 360. I mean, is anterior posterior fixation. Just to clarify, has a higher incidence of morbidity, mortality, and complications. Neurological complications are higher. The risk of it's more common. You get more commonly fractures in the thoracic spine, but cervical injuries are associated with higher spinal cord injuries and poor outcomes. Nursing can be challenging because of the chin on chest deformity. So have a low threshold to get your nutritionist on board, as well as to make sure that people have pulmonary toilet with chest physical therapy. Now, this is, almost everybody here knows what a long lever arm is, which is why the length of the construct is key. And the way I kind of explain this to people is I get them, the normal our spine model. I get them to hold and ask them, where would you hold it? And, oftentimes people hold it in the middle, but then I get them to hold it by their coccyx. And of course they drop it because, the long lever arm, the amount of stress that goes through your hand in order to be able to hold it horizontal. So the evidence-based management. So you can do non-surgical management, although it's not recommended and it's rarely used for patients. There's been 2 occasions that I can remember in the last 10 years where I treated non-surgically with patients who didn't have any 3-column injury, but an extension type of injury with a slight fish mouthing anteriorly with no non-contiguous fractures. But you can get secondary fracture displacement. These are patients that I X-ray every week in a brace, in a TLSO. Be aware that a TLSO is ideal for T12L1 injuries. The further up you go or the further down you go, they don't control it. The further up you go, you have to do a CTLSO, preferably rigid and not one of those soft ones. So there have been some papers looking at successful non-surgical management, but like I said, be very cautious and be very diligent in terms of close follow-up for such patients. The surgical indications are mainly for instability. Osteoporosis consideration, but you don't do surgery just for osteoporosis, and obviously to minimize complications. This is a no-brainer. Fracture displacement, progressive deficits, patients with epidural hematoma with progressive neurological issues, severe deformity, but this is more for chronic situations where you use this for minimizing the chin on chest and to allow people to have a better gaze as well as pulmonary toilet, or a recurrent fracture or symptomatic pseudoarthrosis. The questions that often come up with management is, apart from the operative versus non-operative, do you go long? How many levels do you go? Do you perk it? Do you open it? Do you fuse it versus non-fusion? Do you do posterior or do you 360? Do you augment with cement or not? And do you do in situ fixation versus using serendipitous extension and trying to help with their chin on chest? So this is one of the recent papers in 2021 looking at a nationwide inpatient sample database, and they had 5,385 patients, 77% whites and 7% or 8% Hispanics. The most common level, as we already know, is thoracic followed by cervical. And this is where the non-contiguous injuries, multiple fractures were 13%. Spinal cord injury obviously is high, and about 15% of those cases. And the cervical had a higher proportion of spinal cord injury followed by thoracic. 2,365 underwent surgical treatment. The overall complication rates were 40%, which is significant. And as one would predict, pneumonia and respiratory insufficiency were predominantly the overall issues that cause high morbidity and mortality. There was no significant difference in the complication rates based on levels. And spinal cord injury increased the odds of complication by 2.1 times with a 95% confidence interval, which again is no surprise. This is looking at a review of the disease process, the injury types, the treatment techniques, and outcomes. And this is a systematic review from 01 to 16. Most of those were ground level falls. The delayed diagnosis was 15% to 40%. That's staggering. Again, my dad used to say, what your mind doesn't know, your eyes can't see. So if you can't understand what the X-ray or the patient clinical picture looks like, this can be easily missed as a miss for a more innocent fracture. Hyperextension were more common, and we already know about the prevalence. Deficits were 21 to 100%. That's a high, that's a staggering stats there. Operative fixation was performed in 40 to 100% of patients. Mortality was up to 32% in the first post-injury state. Complications were in their study was 84%. Again, no surprise, but that is very high. Pneumonia was the number one, with respiratory failure and pseudoarthrosis next. Deterioration was reported in 16%. And the key thing here is fusion was successful in about almost 100% of patients from 87 to 100. Deficits did improve in up to 66% in the final follow-up, but depending on the initial presentation, this can vary. So you're starting to see common trends here. So I'm going to skip to some of the other more pertinent questions that we talked about. This is, again, just a review. So fixation options. This is a recent recommendation from the German Society of Orthopedics and Trauma. And this was a literature review and case series. They looked at their own case series and a literature review. Based on that, they said non-displaced fractures could be easily missed. Again, no surprise. MRI should be obtained. Again, it's the same theme as you can see over and over again. Their recommendation was also to maintain spine precautions at all times until definitive treatment, which again makes sense. They didn't recommend any non-operative management. Anterior posterior fixation in their mind was recommended. And we'll talk some of the biomechanical data about that. And close reduction in patient positioning is obviously challenging in the presence of severe kyphosis. In their study, they looked at, in the literature review, extending to 2 to 3 levels above and below was recommended. And they felt screws with cement augmentation in their percutaneous patients helped to minimize the surgical trauma and strengthen the construct because of the underlying osteopenia or osteoporosis that patients get. This is a nice study looking at a finite element analysis because it's difficult to do this out in the field because, or in vivo, because of the fact that you can't randomize patients to this construct because it's not ethical, obviously. So they had 5 groups, Group A to Group E, as you can see, with different fixation options, and they basically looked at different questions, and I'll give you a summary of that. What they were looking for was the von Mises stresses for each of these constructs, and each of these constructs will put reflection extension, lateral bending, left, right, axial rotation, left and right. Based on their summary of recommendations, higher pull-out strength in 4 levels fixation compared to 6 levels fixation, they felt that cement augmentation are recommended in 4 levels of fixation, especially if you're going short as opposed to the conventional 3 above, 3 below, or 3 above, 2 below. The rigid spine and 3-column produced a higher stress, again, no surprise, on the internal fixation compared to normal non-ankylosing fractures. And stress level of 4-level fixation was at least twice less than 3 levels of fixation. Which is, again, the reason why at least 2 above, 2 below is recommended, if not more. Skip level fixation, which is what is working length. And as people know, a working length is basically the distance between a fracture and the screw above and the screw below. So the fracture to the screw above is 1 working length, and below. So that's the working length of the fracture. And in orthopedics, there is value to skip level fixation for the in terms of union and development of callus, but does not represent any superiority in internal fixation stress, force, and yielding force in the Ankylosing patients. The next question is open versus MIS. There are several studies, open versus percutaneous. This was a retrospective review from 2008. This is the old system that, in fact, if you remember the first picture or first set of pictures I showed you, that was a Sexton technique. I don't think we use Sexton, or maybe have a version of that now. The results were that they had reduced wound complication. Again, no surprise. EDL was less, hospital stay and ICU stay was also low in the percutaneous tech, the group, and unconstrained ones had low profile flexibility in the segmental fixation. Here's another study looking at a retrospective review, but only 10 cases, but they felt that you can get good functional outcomes with low complications with surgery that is percutaneous. This was another study, more recent, looking at patients 21 from 2009 to 17, goes to show you how low incidence or prevalence these are. The outcome here, again, was op time, blood loss complications, union rates, no significant differences, particularly the no difference in the union rate, and partly because these patients, the same reason that gets them into trouble by laying down bone and fracturing and like acting like a long bone, is also the reason why they fuse really well once you get a stable situation. This is a retrospective review from 2014 to 18, same conclusion. So the next question is, do you do combined versus posterior? This is a study from 2019, again, a retrospective review with a single institution experience from 1999 to 2015. They looked at demographic data, radiographic results, perioperative complications, and postoperative results, and they concluded the mean operative time was 161 minutes with an EBL of 306 cc. The combined group, 90% of them were staged, and the posterior was first. EBL for the posterior surgery was higher, but the difference wasn't significant. The complication, however, postoperatively was higher in the combined group, but in their study was not significant. Combined higher rate of neurological improvement, but this, again, difference was not significant between the two groups. So the conclusion was they both had good clinical results, but percutaneous technique postoperative, the combined, the posterior had a lower EBL, lower postoperative complications overall, and shorter length of stay combined compared to the combined surgery cohort. But none of these differences were statistically significant. This is another study, I just wanted to highlight one point here. Yeah, so this one, they were talking about the same anterior posterior was combined, but they looked at large anterior gap. They said that would benefit from a secondary anterior bone reconstruction. Again, as I showed you, we have a low threshold to monitor these patients, and if there's significant anterior gap, or doing a percutaneous or minimally invasive lateral technique could be additionally helpful to avoid the overall insult surgically. But that's a personal choice in terms of whether you want to go anterior or not. But always keep in mind, open techniques have a high risk of complications. The spinal cord injury after fractures. This is a retrospective review looking at 172 patients. The predictors for spinal cord injury fractures, the injuries in the cervical spine had a higher incidence, again, in keeping with previous studies, but a fifth had delayed spinal cord injuries. This is where it's important, again, to have really close follow-up for these patients and not let them out of your sight too often. Less than half of those patients that had spinal cord injuries showed improvement. So complications, post-surgical complications in general are epidural hematoma, fractures above and below fixation because of lack of mobile segments. Pseudoarthrosis is also common. Loss of fixation is a big problem, again, with osteoporosis. They don't, because of the segmental fixation, they don't pull out, obviously, but they loosen, and you can actually fracture because of cantilever bending and constant fatigue in the posterior rod. Secondary neurological abnormality, I just want to clarify the loss of fixation. You can get cantilever bending and fractures more so in patients who've got a large fracture gap. If people have attended the AO basic course, they talk about the banana principle, where you take a banana and if you put axial load on the top, the tip and the bottom, you still have enough enough strength so the banana can maintain its position. As soon as you take out a bite out of the concave section, it's very easy to push down. So anterior column lack of support can be a challenge, which can increase your failure of fixation. This looked at major complications of mortality and factors associated. So I'll just summarize it. The posterior approach ICU stay more than 48 hours and spinal cord injury were associated with a major complication, excluding death, and greater than 70 years of age, nosocomial pneumonias were also associated with in-hospital mortality. And anything more than 48 hours of ICU stay was also considered a major risk, including death. So take-home messages are patients with angst are predisposed to fracture, so always have a high index of suspicion. Take them seriously. They're inherently unstable with a significant mortality. X-rays are not reliable. You don't need to have a routine MRI, but have that for reasons for either preoperative evaluation to see if you need to do additional decompression and immobilize in their natural state. I think this is key, and always educate your ER physicians and the paramedic group that serves your emergency room. Persistent pain may be the only symptom that patients can have before a delayed neurological loss. Always be careful and watchful for epidural hematoma, and be aware of pseudoarthrosis, and look up and have a low index of suspicion for a CT scan postoperatively. Again, if you think these two X-rays are the same, again, please look again. Thank you.
Awesome. Thank you, Venkat. So we are getting a little bit close to our 7 mark, for a few minutes beyond 7. But if any of the fellows have any questions, maybe Dr. Ganapathy can answer for them.
Venkat, very nice presentation. I would just add, one of the reasons these injuries are so unstable is because they don't have a ligamentous complex, right? It all gets encased in bone, and the fracture just fractures right through the ligaments. So I couldn't agree more. These are very dangerous fractures.
Well said. Yeah, absolutely.
Well, before we let everybody go, I just want to quickly plug the Bridging the Gap meeting, which is coming up in July. It'll be here in Southern California, and it's the official meeting of the Fellows Conference. If any fellows are interested in coming, they can contact me, and there are some funding opportunities. And we also have a research grant opportunity, which deadline is June 30th. So if anybody's interested, feel free to reach out. Next month, we've got Peter Durman, who's going to speak about endoscopic spine techniques from the Texas Back Institute. And the month after that, for our 20th session, we'll have Dr. Cantor from Hoag. So thanks everybody so much for logging on. Thank you, Venkat. That was excellent. Very salient topic, and hope everybody has a great weekend. We'll see you next
Thank you
month.
so much, Annie. Looks like there's a question. Yeah,
Oh, sorry.
I can give you my
Yeah.
cell phone number so they can contact me separately if you want. If you don't stop enough time.
No, Cam, go for it.
Okay, please.
Yeah, sorry, I don't think my mic was working earlier, but can you hear me now?
Yes, I can.
So quick, it sounds like you're tackling a lot of these percutaneously. What are there any indications that push you to do these open or, in that direction?
I think whatever your comfort level is, I think it's really important you get the job done well, whether it's open or MIS. Obviously, if it's if you're facile with open techniques, then go for it, right? I think whatever the best outcome you can create for these patients, that's ideal. John does a lot of these open, and I think there's really good value. Sorry, Dr. Herbert here in the discussion. Forgive me for that. It does a lot of open cases, but again, it's comfort level. Also, gaining the understanding or knowing that what to expect when you open it. The challenges open are the anatomy is not normal, but if you have open with a navigation, that'd be even better. But when in doubt, always go with your gut in terms of what is normal anatomy, because navigation can throw you off as well, as much as it's helpful. But no, at the end of the day, it's what you're comfortable with, whether it's open or closed. I mean, the key thing is to know that there's no difference in fusion rates whether you open it or close it or perk it. So does that help?
Yeah. I was just trying to see, if there's anything, but thanks for
Yeah,
answering.
I don't know if there's one that I would specifically open. I think if there's any difficulty, I knock on wood, I haven't had to open anything in 10 years. So, but again, the only time I open anything is, but nowadays I just do a minimally invasive a decompression, or even a midline open decompression, leave a drain in if I'm concerned about it, depending on the situation. But that's one of the reasons I would open the fracture site as opposed to the whole back or the fracture segments.
I'd add, Venkat, I think if there's a significant dislocation or a neurological injury that is also part of the surgery, then probably I would very much go open.
Makes sense.
Yeah.
Are there any, obviously a lot of these guys will reduce on the table, but have you ever had to do any other sort of reduction techniques to get your alignment appropriate? Any other issues with that?
Right. So that's important, right? So I just want to clarify your statement. They don't automatically reduce, but you have to allow them to be able to reduce to their natural state by imagining what they would look like on a table, right? They're not going to be normal with their chest, with their kyphotic deformity. So you do have to build the chest up to a certain degree. But no, I mean, you can serendipitously reduce them. There are some folks that, I have conversation with the patient and the family beforehand to see if we can use that extension to our advantage to give them a better chin on chest type of or get him out of a chin on chest type of a deformity. But it's all serendipitous, and you don't purposefully reduce them because there's a risk of neurological injury. But I use my positioning techniques as a way to reduce them. The intraoperative reduction with towers can also be helpful. If you have anterolisthesis, by how you reduce the rods into the towers and the tulips, you can actually translate the proximal cephalad spine back to the rod, thereby reducing the spine. But it's not so much reduction; it's the gap that can sometimes be a difficult one to reduce. But in my experience, even the gap reduces given the settling that they go into, at the level of the fracture. One thing I've started to do more now is have even a short screw at the fracture site. It's one or half dozen the other. The reason why I do that now is because of biomechanical strength, because I don't want the cantilever bending, especially if I've not reinforced the anterior column. But yeah, be careful with the reduction and have x-rays before you start the case. So, and always use neuromonitoring. At least that will be my opinion. I'm sure there's debate about that, but these are patients are high risk for intraoperative neurological injury, so have a high suspicion. So in my protocols, I give them, I tell the anesthesiologist, regardless of their neurological status, to keep their MAP over 85. I give a one dose of 10 milligrams of Dex and have low index of suspicion through the case. I hope that helps.
And it looks like Venu has a question as well. Venu, can you unmute and
Yeah. Hey, Venkat, really nice talk. I just wanted to add one other point on the positioning that I found helpful is using a bendable Jackson frame. If you have it, the nice thing about it is you can actually put the bendable Jackson into kyphosis to actually accommodate the patient's position. And then in a controlled fashion under X-ray guidance, you can then kind of slowly either change the position if you need to before you even start the case, or to help with reduction as you're getting close to reducing the fracture itself with your instrumentation. So one other additional tip that can be helpful if you have that kind of table available.
Absolutely. Yeah. I think that's a luxury. I don't think our hospitals will be able to cough up that much money, but we've been asking. Anyway, yeah, no, great point. It's well said. Yeah. If you have the luxury, please utilize it. Any other
Awesome.
questions?
I don't see any other hands raised.
Thanks,
So,
guys. Thanks so much.
have a great weekend, everybody. And thanks again, Venkat.
Thanks, Annie. Thank you so
All right.
much.